This conference will now be recorded.
Okay, good evening, everybody. It is May the 5th, 5/5/25. That's a nice date, isn't it? Nice round date, 5/5/25. It's my best buddy's birthday. I called him in London today, or in England. And it's the high risk recurrent advanced group, prostate cancer group. This is Rick Davis. I am moderating the group tonight with the able assistance of Len Sierra and Dr. John Antonucci, and anybody else who would like to chime in, but those are my co-moderators. We have 3 new men, so we're going to have to try and move pretty quickly. We also have how many? 1, 2, 3, 4, 5, 6, 7, 8. 8 people that need time. So we are. I will ask people to mute because I'm getting a little bit of feedback. So if you can mute, that would help us, and then turn on when you need to talk. All right, I will receive the new men in the order that they arrived, or I welcome them. So we're going to start with Stephen T. I will just say for all the new men, and probably we will repeat this, if you are not signed up to receive a weekly reminder before each meeting, please put your email in the chat window. And let me just tell what everybody, especially the newbies, where the chat window is. It's those 2 little squares in the top next to the box that says 41. And you can put your email in there, and you can send it directly to me by clicking where it says everyone and picking my name, AnCan Rick, out. Or you can put it in for everyone if you want other people to have your email address. But we ask you to give us that address so that we can send you the reminder. We don't spam you. You will rarely hear from us. Now, Stephen T. Hello.
Hello, Rick. Can you hear me okay?
I can hear you, but I can't see you anymore, but that's okay.
Yeah, I've turned off my camera.
Okay, that's just fine. How old are you?
I am 68. I will be 69 next week.
Oh, happy birthday for next week. Where do you live?
I live in Wisconsin.
Okay. What part?
Southeastern.
So that's like Milwaukee?
Near Milwaukee, yes.
Okay. One of the reasons I ask is because for people in Wisconsin, we like to navigate them to Madison, but that doesn't work too well if they're up in Green Bay. So Steve Rue isn't here today. Maybe he'll come in later. But we have some other people that are in that part of the world. When were you first diagnosed?
It was late February of this year.
Okay, 2/25. And what was your PSA level and your Gleason score on diagnosis?
In April, my PSA was 8.52, and my Gleason score was 4 + 5 = 9.
Okay. And where were you treated, or where were you diagnosed?
At the Frederick and the Medical College of Wisconsin.
Yeah, okay, I'm familiar
Milwaukee.
with the medical college. Close to Milwaukee. What type of doctor was it that diagnosed you, and what made you go to the doctor?
I had been seeing a urologist regularly for PSA tests during my annual physical exam, and it had been creeping up gradually over the last few years.
Mm-hmm.
And it went up to 9.52 in December of 2024. And that's when the urologist said, we should get an MRI.
Mm-hmm.
So I got an MRI of the prostate, and then that came back with that found a lesion with rated as a PIRADS 5.
Mm-hmm.
And so then I got ultrasound fusion guided biopsy.
All right. Let me.
Sorry.
It's fine. It's all good information, but because we have three new guys, I got to move a little bit quickly. The person at the medical college, was that a urologist that you saw there who finally who diagnosed your 4+5?
Yes.
And it was with a fusion biopsy. Was that transperineal or transrectal?
Transrectal.
Okay. And when they found that you had a 4+5, did they do a PSMA scan?
Yes.
And what was the result of that?
No metastasis.
Good. Okay. So, and I'm assuming that the other scans, if they did any other scans, that they were all negative as well?
There were no other scans.
Okay, they just did a PSMA. It's interesting. It's interesting that now a lot of people are sort of just relying on the old PSMA. They used to do a CT and they used to do a bone scan, but the only problem with that is there's a small percentage of people that don't make PSMA, and I'm not sure how they're going to figuring out who those people are. And so I would rather that they did some other type of scan as well as the PSMA scan. And that's something you might want to mention to your doctor, that you're well aware that there's about 15% of people that don't make PSMA, and you just want to make sure that they're taking that into account. So what was the treatment that was recommended?
I was given the choice between robot-assisted laparoscopic radical prostatectomy or radiation plus hormone therapy.
And have you started treatment?
I have not.
Okay, well, that's good. And so one of the reasons you're here, I think, is probably to talk about which way to go. Is that right?
I'm leaning toward the surgery, but yes, I would like to discuss that.
Okay, so have you run the MSKCC nomogram?
No.
All right. Would somebody, John or Len, would you be kind enough to put the MSKCC nomogram in the chat window for me, please? Let me explain to you what that is and why it is really, really important for somebody in your situation right now. Do you know, are you familiar with nomograms?
Yes.
You are, good. Okay. So one of the problems with most nomograms is that the way that we treat today has changed so much over the last 5 or 6 years that there is a bias, but it's not a huge bias, but we do recognize that there is a bias because 5 years ago we weren't checking people like yourself with PSMA scans, and that can really change. Alfredo has been kind enough to put the nomogram Dr. Alfredo has put it in the chat window. You can just click on that in the chat and it'll open in your browser. You can look at it later. Now, the one you want to run is the radical prostatectomy, and it's going to tell you based on a number of factors like how many positive cores you have, what your Gleason score is, what your PSA is, what your age is, and other things, how likely it is that you will need additional treatment after your radical prostatectomy. Now, I can speak on this one from experience, and in my case, there was a 30% chance that the radical prostatectomy on its own would be sufficient. How many, I didn't ask you this, how many cores were positive in the biopsy that they did?
I believe it was 6.
And how many did they take in total?
15.
Okay. And the 6 that were positive, were they all, what were they? Were they 4s and 5s, or what? Do you recall what they were?
4, 5, and 3.
Okay. So you had some 4+4s, some 4+3s in there. You may need to know, but the fact that you had a 4+5 is going to be the key issue for the nomogram. And I suspect that the result that will come up will be that you will have a less than 30% chance of no recurrence. Now, knowing that, you can make a decision whether you want to do surgery and then face hormone therapy and radiation, or whether you want to bypass the surgery and go straight to hormone therapy and radiation. So by taking on the surgery, you're incurring a whole nother set of comorbidities and side effects, and we'll open this up because I know there are men who want to talk about this to you in this group. And the benefit is very hard to measure. They've never ever done any studies. I personally, or somebody on my behalf in the past, this is going back to 2007, we've asked some highly experienced and reputable urologists, what do you think the benefit is of doing the surgery? And the best number we can come up with is around 3%. So it improves your numbers, whatever you want to measure your numbers by, whether that's overall survival, radiation-free progression, metastasis-free survival. It makes them about 3 or 4% better. For me, it wasn't worth it. So I passed on the surgery. And I went straight to radiation and hormone therapy. In your case, we can talk to you about the options for radiation therapy because there are 2 or 3 different options. Hormone therapy is likely to be plus or minus 24 months. And we know that something like either an SBRT to the gland or brachytherapy to the gland, plus some 20 sessions across the pelvic girdle, plus 24 months of hormone therapy is pretty much the gold standard. That's going to get you about the best survival. So that's where we are. Why don't you tell us what your questions are, and then I will open it up to the group, because we do have men here who have gone the other route, who have gone surgery first, and I think they would probably like to have a little chat with you.
Thank you. I'm leaning toward the radical prostatectomy because I have an enlarged prostate, and I've been told by not only the surgeon but another man who's had the prostatectomy that it will resolve my weak stream problem and my urinary frequency problem. So I'm wondering if anybody else in the group
Right.
could comment on that. Would they agree?
Right. Hands up. Who would like to talk to Stephen first? And Stephen, please let me have you signed up, or do we have your email or not?
I have not signed up yet, no.
Okay. So either send me your email or you can sign up on ancan.org, and so that we can continue to send you. How did you find us, by the way?
I was referred by Don Rogers of Boca
Oh, yes.
Raton, Florida.
Yeah. Okay, yeah. So you can even send Don out your email and he can pass it on to me. But we'd like you to keep coming back so we can continue to support you and hold your hand through this decision-making process. It's a difficult time. Okay, we've got two hands up so far. Jeff Marchi, let's go. And guys, try to be brief if you can, please, because we've got two other new men.
Did you know that they have found either cribriform, seminal vesicle invasion, or introductal when they did your biopsy? Because those are some important issues that can cause more problems. I just wondered if you know if they were seen. Cribriform, seminal vesicle invasion, or introductal.
Seminal vesicle is negative. What were the other two you mentioned?
Cribriform and introductal. CRABRIFORM.
I don't remember seeing either of those terms on any of the reports I've seen.
That's good. As far as your question about urinary problems, sometimes people have them, sometimes they don't. It's just all over the place after surgery, whether or not you're going to come out with absolutely no problems. You may there's incontinence issues for a lot of people that go on for a long time.
Jeff, it was a different question that was asked. The question that was asked was, have any guys who have had issues with their flow before they go in, has it been resolved by the treatment or by the surgery?
And that was the point I was trying to make, that for some people it does, and for some people it doesn't. It is a problem for some people after the surgery.
I think it's sure to cure his urinary restriction. There are way easier ways to cure your urinary restriction.
Okay. Let me just say one thing to you, Stephen, and then I'll go to the next person with their hand up. We often suggest to people, and it might not be a bad thing for you to do, is to get a second opinion on your biopsy. I mean, it's sort of debatable because you're definitely going to go in for treatment. Will it influence you one way or the other as to which treatment to go for? Well, if the 5 were confirmed and it turned out that there was cribriform or there was introductal, it might encourage you to go towards to avoid the surgery. If you do want to get a second opinion, then we would suggest going to either Dr. Epstein or Dr. Zhao. Both of them are in New York. We can provide you with the information. Somebody will hopefully be able to put that in the chat window for you. It could be another important piece of information. It takes about 2 weeks to turn it around, and the medical college will send it directly to either Dr. Zhao or Dr. Epstein. But we often...
excuse me, Dr. Zhao has my biopsy specimens right now, and
Oh,
I was
great.
hoping to hear from him today with a report, but
Oh, great.
apparently he's
Okay.
delayed. So hopefully I'll hear tomorrow.
Yeah, and you can talk to him as well. Tell him you're an AnCan person, and he'll talk to you. He's very, very good. He was trained by Epstein, by the way.
Very good.
That's yeah. Okay, I'm glad you're doing that. Um, let's see, Harry, you have your hand up.
Yeah, I just wanted to share my experience. I had the radical prostatectomy.
Okay, well, Harry, if I'm not mistaken, you're new, right?
Yeah, I'm new and I put up the hand by accident and I don't know how to take it down.
Ah, okay. Well, we'll come to you to hear your story
Okay.
momentarily. Is there anything you wanted to say to Stephen?
No, I had radiation and
Okay, so
Yeah, I had my hand up, Harry Spila, different Harry.
Harry. Oh, that's Harry S. And Norm
Yeah.
Pollock had his hand up. Norm Pollock, do you want to say something first before Harry S?
Well, I had the radical first, and I was within a couple of months I was continent and could get an erection, and then I got biochemical recurrence and got the radiation and the ADT, and all that went out the window, and has been out the window ever since. So I don't know if you get somebody that's good. And I just talked to a guy 2 days ago who had the radical, and he's continent and can get erections. So depends on what's real important to you, I guess. So it's a gamble.
What was your Gleason score going into the radical?
I was a 9.
You were a 9.
Yeah.
And it came back how quickly?
A year.
Okay.
Almost a year to the date.
Okay.
So.
Harry S., how are you?
Good. Just a short story on mine. In 2016, I decided to have a radical prostatectomy, and looking back, I probably wouldn't do it again. But that said, not all the technology was available then that's available today. And all I would say is use every possible venue there is for testing and scans to help you make your decision, because I went by my surgeon who guaranteed me, or didn't guarantee, but he was very sure that they would get everything. And once they got it in there, well, it was another story. So, but again, back in when I had it done, there wasn't all these scans and things available that's available today. So get all the information you can, because the side effects from surgery, can be life-changing. So, and I do urinate great now, but there's some other impacts that come along with the surgery. That's just my 2 cents.
Thanks, Harry. Norm, did you want to add something? You're muted.
Norm, can you hear us? You're muted.
I just wondering, all you guys that just had radiation and didn't have the radicals, how's your incontinence and your erections?
I mean, I certainly didn't have a problem for quite a long time. I have a problem now, but I didn't for many, many, many years.
Okay. It all depends on what's real important to you. I mean, so whether it's worth a gamble or not, I guess. So, but the radiation keeps adding up, where the radical gets better.
Right.
If you don't reoccur.
Yeah. I'm going to pick on David Muslin because he always says if he knew then what he knows now, he wouldn't have done he wouldn't have done the surgery. Mr. Muslin?
Yep, you're 100% right, Rick. If I could go back in time, I would pass on the surgery and go right to radiation. I struggled, and it changed my sex life and changed the size of my penis, and like Rick said, it's a small amount of men where it really works. So, and with a PSA score that you have, I would personally, if I were in your shoes, I'd go right to radiation.
Okay. Richard Fisk, and then we've got to. That's going to be the last comment on this. I'm afraid.
Was diagnosed with Gleason 9. I went through basically a tumor board at Walter Reed Military Medical Center, and I pushed for surgery, and they said radiation because there were too many potential negative side effects, and I was 76 at the time, so I was too old. I got a second opinion from um, uh, Johns Hopkins and was told I wasn't eligible for radiation for surgery. I should get radiation. Talked to my brother on the West Coast who hit up all the people in the University of California, San Francisco area, and smart mind said radiation. That's what I went with, and haven't looked back.
Thank you.
Thank you, Captain. So, Steve, this is just the beginning of the journey. Please come back. Tell us what Dr. Zhao said. Have you had any genetic testing?
No.
Okay. Well, you do want to. You should get. Do you have any history of cancer in your family?
Yes, my sister had breast cancer, and I've had cancer before, 30 years ago.
Okay. And what type of cancer did you have before?
I had a chondrosarcoma.
Okay. The bigger concern for me is your sister having breast cancer. Do you any history with your parents?
No.
No. I mean, if nothing else, get some genetic testing. I'm going to put I'm putting a link in the chat window for you now. This is a free test through Promise. They still are doing it. It's actually the color test that they offer. It's part of a clinical trial with Johns Hopkins and University of Washington. And, click on that, sign up tonight. Have them send you all the information. Don't send it through the doc. You'll get a screening if you need it, but at least let's just make sure you don't have a history. You're not carrying any sort of genetic mutation, and so there you go.
Thank you. And may I ask one more question before
Yes.
we move on?
Yes.
This one is really important to me. I'm wondering how someone with prostate cancer, it's an idea of the urgency for beginning treatment.
Yes, a reasonable question. So let me give you what I was faced with, because it'll probably help you. I was diagnosed I had high PSA and was set up for biopsy in May. I had a confirmatory biopsy. I had the biopsy which confirmed, and I got a hard diagnosis in August, and I was a 4+4 with disease outside the prostate. And my doctor said to me, you really need to make a decision no later than the end of the year. And I made a decision within about less than 2 months. So, we can't give medical advice in here, but I would say time is of the essence. If you make a decision within the next 4 to 8 weeks, if it were me, I'd be probably trying to make a decision within the next 4 to 6 weeks, 4 to 8 weeks, if it were me.
I had surgery scheduled for April 30, this past April 30.
Yes.
And after talking with some people in the Reluctant Brotherhood, I canceled it to take some time to do some of the things that you're suggesting. And my stress level has just gone through the roof. With the previous cancer I had, the sense of urgency was very strong, and I had that treated
Right.
with surgery almost immediately. So, and I've been asking all the health professionals I've encountered what they think the sense of urgency is, but they're very reluctant to give me any time frames. So thank you. That's very helpful to know.
Look, if you feel like you need more time and you really want to do something in the interim, you can certainly do start some hormone therapy. You're going to need it if you choose radiation, and they'll start you on it before the radiation. And we haven't even talked to you about the different types of radiation, so we can do that next time. But it probably won't hurt the surgery either. So if it's going to give you some relief, then talk to your doc about getting onto Orgovix or Relugolix. But I'm afraid I have to move on because we've got two other new gents and we've got a bunch of people that need time. So forgive us. Let us have your email so we can get in touch with you. We can connect you to some of the gents who are in this group. If there's anybody you want to connect to immediately, reach out to them through the chat window.
Thank you, Rick, and thank you for everybody that volunteered.
Okay, Jeff W. You've heard the routine. How old are you, sir?
Also 68.
58. Okay. Just to let you know, we also have an under 60s group with a bunch of good guys, really good guys in it too. And that sort of focuses more on some of the more special issues. I was 56 when I was diagnosed. So. And where do you live?
In Texas, about 10 miles south of Austin.
Okay. Unfortunately, not a great area for prostate cancer treatment.
Well, I have been to MD Anderson. Does that mean anything to you?
Yes, it means something, and you're a lot better off at MD Anderson than you are anywhere in Austin. When were you first diagnosed?
July of 2021. I should say that I got here also as a result of being recommended. Don Rogers also recommended that I actually talk to you. And then I talked to Steve last week at the Reluctant Brotherhood meeting. He sent me along the link to the meeting tonight. I am favorable intermediate, but I missed the favorable intermediate meeting on April 21st because I had a hernia fix that day.
Okay. So
that's how
if you are favorable intermediate, so favorable intermediate meaning a 3+4?
Correct.
Yeah. This is not the right group for you.
Yeah.
Okay. What I recommend you do, and we'll get you signed up, I've got your email here, is come back next Monday night, same time next Monday night. And Dr. Mark Perlow runs that group. I am usually present in it. So is Dr. John Antonucci usually in that group. And we will take you through all the decision making that you need to do and help you navigate. Now, I should say this. Sorry, I just realized you said you were first diagnosed 7/21.
July of 2021 and was on active surveillance until August of this year when I had a biopsy and they found Gleason 3.3 had gone to 3.4.
Okay. So yes, if you were first diagnosed 2021, if you've been doing AS, I would also suggest you come to the AS group on which is Wednesday night.
Okay.
In this room, same time, because even if you've only gone from a 3+3 to a 3+4, that doesn't rule you out of continuing AS. And those are the guys to talk to, because there's a bunch of guys in that group who are favorite intermediate doing AS.
Okay.
Okay. This group is for men who are high risk, like Stephen T, or who have recurrence, or who have definite more advanced disease.
Okay.
And we don't want to scare you. You are very welcome to stay, but if you think it's going to disturb what you hear, we don't encourage you to. If it's not going to bother you, you're very, very welcome to stay. It's totally your choice. We're not throwing you out, but this is really a more advanced group.
Okay. I appreciate it. Thank you.
Okay, and so the two meetings again are Wednesday night at hold on a minute, 7 o'clock Central, because you're on Central, correct?
Correct.
So this Wednesday night in this room, 7 o'clock Central, and then next Monday, which is the 12th, 7 o'clock, and that meeting will talk about treatment. We don't talk about treatment options in the active surveillance group. We talk about keeping you on active surveillance.
Okay. Okay, that sounds good.
Okay?
Thank you. Thank you.
My pleasure. My pleasure. And I will probably see you in one of those groups, and we'll go from there, okay?
All right, thank you.
All right. And so we move through to Harry Schoenberg.
Okay, yes. Good evening. I'm afraid you're not going to kick me out. I think I'm in the right place.
Okay.
I think I'm in the right place.
Okay.
You should be wishing you would be kicked out of this group, not afraid of it.
Yes, I agree.
All right. I see you've got a Z. Is the Z for Zvi?
It is, actually. That's very good detective work.
Yes. Well, no, it's because Harry and Zvi and Hirsch, they all go together.
Yes,
and they, it's all related to deer.
Yes.
With two E's. So, Harry, how old are you, sir?
68.
68. And where do you live?
Fairfax, Virginia.
Oh, we got a few neighbors for you in here, I think. How did you find us?
Well, my wife told me about it, and I've listened in a few times and to recordings a few times, but it's my first time to participate.
Okay. Well, we definitely have a few people who are in your neighborhood. So, and they'll reach out to you, and they'll send you in the chat window, and you can probably get together with them and what have you, or maybe they'll even speak up during this meeting. So, but it's a popular area for AnCan. Don't ask me why. When were you first diagnosed?
January 2018.
Okay. And what was your Gleason score at that time?
4+4.
Okay. And what was your PSA?
It's about 5.2.
All right. How many cores were positive?
12.
Out of?
Out of 12.
That's what I thought, because it was a systemic biopsy at that time. And how many were 4+4s?
A bunch of them. I don't have the data with me, but
it's
a bunch.
Okay.
Yeah.
A bunch is good enough for us because we're very technical here, so we all know what a bunch means, right, Dr. John?
Yeah, exactly. Precision is our watchword.
Which institution? Where were you diagnosed? Which institution?
I was at the Kaiser Permanente program then.
Yes.
And I've subsequently moved over to Inova Shar Cancer Institute.
Okay, well, that was a good move. because we've got both Kaiser, we've got people in your neighborhood who are at Kaiser, and we've got people in your neighborhood who are at Nova Shah who are present on this in this room tonight. So, and I, by the way, was a Kaiser patient in California, but lucky enough to get my treatment at both Kaiser and UCSF at the time.
Mhm.
I was just really, really lucky. So, what treatment did you have back in 18?
They started me with Lupron and then radiation. It was 180 CGY is the unit daily, and 7920 CGY total.
So you had 40 odd sessions?
Yeah, 45, I think. Yeah.
45 sessions of IMRT.
Yeah.
Okay. And how long did they keep you on hormone therapy for? On Lupron for?
So I think I'm still on my hormone therapy. I was switched from Lupron. When I went to Inova, I got onto Eligard, and I'm still getting that every three months.
Okay, so let me back up a little bit. What year did you switch from Kaiser to InnovaShare?
So I switched in July 22.
Okay. So what was the result? First of all, before that, did Kaiser scan you initially?
Yeah, I got scans at Kaiser, and I got an Alumin PT scan in February of 21. And that's where they found some metastases.
Okay, let's back up. Let's back off before we get to the Axumin. Before you began treatment, they didn't see anything on a bone scan or a CT scan, correct?
No, I don't think so. I'm trying
Okay.
to. I went back to my notes, but I don't think there was. No.
Okay. Your wife's very welcome to come in and join in. We
Yeah, she's
love
a
it when,
landsman of yours.
we love it when the care partners are there, as you saw with Regina at the beginning.
Right.
So what happened at the end of that 45 sessions? Where was your hello?
Hello.
Where was your PSA at the end of the 45 sessions?
So at the end of those sessions, it went down. It went. I can look through this for a figure, but it was. My PSA has never been especially high.
Right. What was the lowest it ever got to?
Oh, undetectable.
Okay, so it did get to undetectable, and that was roughly how long after you finished the radiation?
Okay, I'm looking here.
I think it was always below 1. It was below 1.
In my days of, okay, so I finished the radiation right around there, 0.03.
So when you finished the radiation, it was at 0.03.
Yeah.
And then how long before it started to climb?
Okay. So about a year. It began to climb in the summer of 22.
He stopped after he finished the radiation
Yeah.
and he was on the hormone therapy. He stopped the hormone therapy. You did stop the hormone therapy. And then your PSA started to rise, I think. And that's when they did the Axiom PET scan.
The Axiom. So let me hold on a minute and let me back up. How long did you do the hormone therapy for?
I think it was about 18 months. Was
The
18
Lupron?
Yep, 18 months. When you after your radiation.
Yeah, but I
months.
continued with it afterwards.
Yeah, but there was a gap.
Yes,
there was a
gap. That's what I was asking you before. How much Lupron did they give you up front? 18 months?
Yes, I think it was 18 months.
Because again, that's light. Usually, I mean, I did 28 months. So if they stopped at 18 months, that sort of tells us a little bit. Now, this takes us through to about 2021. You switched over to an overshare. They did an Axiom scan, and
No,
they found.
I'm sorry to interrupt. The Axiom scan was at Kaiser.
Oh, the Axiom scan was at Kaiser,
Yeah.
and what did they find on that Axiom scan?
There was an 8 millimeter growth in the iliac lymph node.
Right.
With a 4.1 SUV avidity. And they did an MRI a month later, and they found diffuse metastases in the pelvis, pubic ramus, and they found that one in the iliac node.
Okay. So they found it in the pelvis, in the iliac node, and where else?
The pubic ramus.
In the pubic ramus, and
in the bone.
In the bone,
right.
They said there was a fracture in the bone.
Okay.
Due to
let me keep going. I've got to go relatively quickly because we've got a lot of guys to get to. Now, you then, when did you switch? Was it right after that, or how did Kaiser respond to that? Did they suggest spot radiation? Did they suggest?
Yeah, so they put me on abiraterone.
Okay.
That's when he moved to see the oncologist. When they saw that there was some spread, he went to the oncologist in April of 21, and she put him on abiraterone.
Okay.
And they sent me to the radiation oncologist who took the cyberknife radiation to the pubic ramus spot.
Okay, so you did spot RT, and the oncologist. Who was the oncologist?
The oncologist, Dr. Ahuja, Nita Ahuja.
Yeah, I don't know. We'll find out from some of the guys in a minute. And then you did spot RT. They added abiraterone, and then you switched over to an overshare.
Yeah, but in the meantime, I began Zometa, and I came back with a genetic test telling me I was BRCA1 positive.
Germline or somatic? Inherited?
Inherited, yes.
Ah, okay. Well, we'll add you to our. Did you say BRCA1 or BRCA2?
1.
Okay. Well, there's good news and bad news. The bad news is you got an inherited mutation.
Mm-hmm.
The good news is, believe it or not, that's not really the Ashkenaz mutation. BRCA2 is more the Ashkenaz mutation. And the other thing is that we seem to think that BRCA1 doesn't have much an effect on prostate cancer. BRCA2 definitely does, but the most recent research suggests that BRCA1 has much less of an impact. That said, it does make you a candidate for a PARP inhibitor,
of which he is.
Which
he's beginning to fail on, which he has now.
Yeah.
Okay, so what are you on, olaparib?
Olaparib
with abiraterone.
And when did you take? So you're on Abi. You're on Abi plus olaparib. When did you start the olaparib?
October of 23. So it's a year and a half now.
Can we go back?
Who's your medical oncologist at AnCan?
Dr. Aragon Ching.
How'd you like her?
I like her.
Okay.
Can we just go back a little bit, because
Yes.
he had a spike in August in his PSA, and then there was a PSMA PET that didn't show much avidity. However, he had a hydronephosis of the ureter. So there was a growth on the outside wall of the ureter, which is
Okay.
unusual in prostate cancer, is what we understand.
Yeah.
And they did another PSMA PET, and that's at that point in time his PSA was over 7, right? It was nearly 8, 7 point.
Peaked at 7.6.
And then they did another PSMA PET, and then it showed that area in the ureter was prostate cancer.
It was avid on the PSMA
avid.
PET.
That's what I was going to ask you. So whatever this growth is on the outside of the ureter, we know that it is prostate cancer, correct?
Right. Yes.
And that's when she started him on olaparib and abiraterone, and then that's been what, it was a year.
Well, that was October 23. So that actually began.
Time out. I thought you said that you added the abiraterone back in 21.
Yes,
correct.
But she's doing the dual therapy with olaparib and
with the olaparib. Got it. Are you on? Are you taking that single pill?
No, I'm taking like 4 pills.
You're taking
Akiga. Okay. That's Akiga.
Akiga. You're not taking Akiga?
No.
Okay. Which is probably fine, because but there is an abiraterone olaparib pill together. But she may be playing around with the dosages, and
she did.
She brought me up low. She started low, and then she added more.
Okay, so now what today? 525. What's your PSA right now?
So my last time I had the PSA checked, which was about a month ago, was 1.88.
Okay, so you're responding pretty well to that.
Except it's rising now. The PSA is rising.
It's been rising and almost doubling since like December. It was 0.2 and then 0.3 and then 0.6.
All right, there it is.
Okay, whoever that is, Russ, we need you to mute, please. Thank you very much.
And then say the scan.
So it's been doubling since December. All right, I think that's about as much information as I can gather right now.
Can we just tell you that the last scans that he had, and she likes to do bone and CAT scans.
Yes.
They were stable, but there's this issue now that possibly he's maybe failing olaparib, and the question is what's next, and does he switch to talazoparib with enzalutamide? There's a clinical trial there, so we're feeling very in a quandary right now.
Yeah, got it. Well, I'm going to throw this out and see what people think. Let's take 10 minutes, and then a quarter after the hour, we've got to move over, I'm afraid.
Thank you. Should I just mention the clinical trial is called Omaha 4. It's for opevesostat, which is now bought by Merck. I don't know if people are familiar with that one.
What's the name of the drug?
OPEVESOSTAT.
And it's the trial's called Omaha.
All right. Well, I am not familiar with it. We will take a look at it. Is it being run out of a NovaShare?
One of the sites, but
it is one of the sites. And is Is Aragon Ching the investigator?
She's on, yeah, she's listed on it.
Okay. So we'll talk about that momentarily, but you know, it always raises a question for me. Dr. John, you're probably looking, or Len, you're probably looking at it right now. Do you need the NCT number? Do you have the NCT number there, Harry?
Yep, it's 0613-6650.
Okay.
Are you working on that, Len?
I think we woke Glenn up. He's muted. It's just as well he's muted.
I was muted. Yeah, I'm working on it. I've heard of Omaha. I'm just curious if he would be eligible for that clinical trial since he's already failing Abby and olaparib, and they want to put him on another enzalutamide plus, another PARP inhibitor.
Well, first of all, okay, that's a whole different question, and he's not failing anything. They're failing him, Len.
I don't think she wants to, but she put it out there.
Yeah.
There isn't much data out there, but she put it out there, and that was
well. I do have some other ideas, which I will pose in a second. What I'd like to do is throw this out to anybody who would like to talk to Harry, first of all. No one? No one's got any bright ideas for Harry? Or his wife? Wife, do you have a name, please?
Ingrid.
Ingrid. Okay, Ingrid, thank you. Got it.
Oh, did they discuss chemotherapy at all with you?
That's always out there, but not so much in the near term. I mean, they haven't. So we haven't had those discussions. We've had about 2 appointments in a row now, where basically we go around in a circle on these different options, and we say, well, you don't have to rush into it, and we say, let's give it another month, and then my PSA is up again. Although the numbers are still low, but of course, when they start rising, they rise.
We're waiting. It feels like we're waiting for the other shoe to drop, which is, that's where we feel we are, which I understand it's not a clear-cut thing, but it's, we had a very frustrating meeting last time, I felt, because this clinical trial, I don't think he's not really sure that this is the best way for him to go. And she's not pushing us, but we don't think that's the best way. And then, out there, we know that we feel like the options, it would be chemo and then maybe Pluvicto, and we're feeling, I think she's trying to push everything so that we don't get to those options yet, but she's always said chemo and then
well, the chemo was because of the old indications. You couldn't get Pluvicto without going through chemo.
But she still wants you to.
But Pluvicto, she said very clearly that she doesn't think I'm ready for that yet, that she wants to hold that back and keep it in reserve.
Well, why would she want to do that? I have to say, I have a little bit of a bias because she's a very nice lady, but she's not one of my favorites. I wouldn't send people to her personally. I don't like the way she manages. I personally don't like the way she manages her cases because we've seen it. We know that you can retreat with Pluvicto, and especially now that you don't have to go through chemo first. There's also another trial that's out there, which we will know a little more about tomorrow, but there is an open trial right now with a different type of ligand, but using Lu-177. where you can go through the whole treatment in 2 weeks.
Is this the telex that you put in
Yes.
the newsletter?
Yes.
Yeah, 'cause I read about it on Saturday
Right.
morning.
And so, one of the things that we know is that you can retreat with radioligands, number one, and number two, it may be that chemo is more effective after a radioligand. There's some weak evidence out there about that. Frankly, what I'd like to see, depending if you're willing to travel or not, is I'd like to see you get a second opinion. And I'd like to see you get that second opinion from a center of excellence, and I'd like you to run any trials past another GU medical oncologist at a center of excellence. And we can help you. We have recommendations, people that we can definitely send you to. But you may well be a very good candidate for Pluvicto right now. I mean, to say, well, I'm holding it back, for what? It's like saying I'm holding chemotherapy back. One of the things we can do with chemotherapy right now is treat you more than once with chemotherapy. We can treat you now. You could have Pluvicto. We could treat you again. And Pluvicto is the same thing. And it's kind of old school to say, well, I'm holding you back. That's our view. Frank Chambra, what would you like to say?
I want to address. I don't know what your name is or your wife's name, but what your wife said about she feels like she's waiting for the next shoe to drop. That was a very important thing you said right there. I mean, I don't know about anybody else, but I've been in that situation, and you're not really waiting for the next shoe to drop. It's that there's a lot of decisions to make. I mean, I'm on Pluvicto now. I just finished my 6th treatment. So but I don't even know what your medical case is. So I can't address that, but I know where I'm at. But I want to say is that I felt that way, and it was probably because the doctors, I didn't really feel comfortable with them. And I just felt like they weren't really being straight with me, And then it's the journey to go through that. It's sad that we have to navigate all of that crap, So just take your time and make a lot of decisions. But the shoe's not going to drop because we're still living.
Mm-hmm.
That's when the shoe drops,
Mm-hmm.
So let's thank God that we're alive. And I'm not dying from cancer. I'm living with it. So anyway, that's what I always say. And what you said is very, very important. Don't dismiss that. Just wanted to say that.
Thank you.
Thank you.
I think what you're saying, we're feeling, we've been talking that maybe we need to move on and find, it's almost like a second opinion at this stage of the game. And that's what we've been feeling for, I certainly been feeling, and I think he's coming round to that. But that's where I think we would like some help and some suggestions would be very appreciated.
There's a couple of ways to go. If you've got good docs who are flexible, then maybe sometimes they're willing to work with other docs. But some of them get offended and they don't want to do it. And it makes life more complicated, because then we've got to find providers for you in your area, and you've got a quarterback who's outside your area. So part of this decision is talking with who you're getting your second opinion from. I'm not, well, the best person, probably, she's very good. She wouldn't be my first choice, but she's the most convenient, is Channing Paller. P-A-L-L-E-R at Sibley.
Yep.
And You've heard of her, I think.
Yeah.
And we like her. We've got people in this group who are seeing her right now. She is good. I don't know that she would be my first choice if I was willing to go anywhere in the country.
What about Sloan Kettering or
Johns Hopkins?
Well, Hopkins is Pala, and she's probably the best of the bunch now. We're not fans of Carducci and or what's his face, Mr. BAT, Demmead. But I would say Pala. If you wanted to go up to New York, yes, we can. We've got people that we could send you to, a couple of people at New York, at NYU, that we like. We've got a doc in Houston who is really creative and very, very good, and very good at working with local people. And I kind of think she might have and also very good in terms of evaluating the trials. My gut tells me that I would go see Dr. E. That's what my gut tells me.
That's the one in Houston?
That's the one in Houston, Eleni Evstathiou. And we have a couple of people in the group here who travel to see her. I'll put her. She was 14 years at MD Anderson. She's now across the street at Houston Methodist and doing her own thing there and trying to set up a center of excellence. But she's really, really good.
And she'd work with like.
I don't know what her arrogant. Yeah. I don't know what her relationship is like with arrogant Ching. That's sort of why you'd have to sort of ask her.
Okay.
But she's the sort of person that you can ask.
Okay.
Okay. She'll tell you. But I would my choice probably would be either Eleni. I'm just going to put Dr. E for. I'm going to put Eleni in there and Channing Pala. Channing Pala,
Yeah.
So you don't need me to put her details in there. Let me throw this out very quickly. And guys, we've really got to move on because we've got 8 of you that need time. Anybody else want to say anything about a second opinion?
I'll just put in a 2 cents. I think a second opinion is a great idea at this point. I would not be too eager about the opevesostat trial at this point when you have some mainstream drugs that still have not been tried.
Thank you.
Okay, thank you.
Has anyone got thoughts about Dr. Morris at Sloan Kettering?
Well, he's great, but it's very hard to get in to see him. I frankly doubt that you'll be able to get in. He's not taking new patients.
Okay.
If we were sending you there, we'd probably send you to Dr. Rathkoff, who's terrific. She's lovely. She's very compassionate. Possibly Dr. McHugh. Who else? I've got to think who else quickly. But I would probably say, Dr. Rathkoff or Dr. McHugh right now. Dr. McHugh's Irish. And we've got a guy. Well, one of the reasons I'm sort of thinking Dr. McHugh is because he's doing some work with PARP inhibitors right now. He's running a PARP inhibitor trial on people that are newly diagnosed and giving them PARPs before surgery. So, it's obviously an area of interest. And the guy that we have at that trial really likes him. So it might be a good fit. And I'm sure we could get you in.
Sorry.
I was just saying, if you can't get in, I can work through our guy who's with him right now, and we can get him to see you for a second opinion.
Okay. And Dr. Pallet Channing pallor, would she be good? Just because and convenience does help, when you're.
Yes. Well, you can get more than one second opinion, and I probably would. I mean, she's very good. I don't know what her specific interest is. Jim Marshall is seeing her right now. Right, Jim? And have you seen her yet?
Yes, I have.
Okay.
I saw her about a month and a half ago.
Yeah. She's very good, but she speaks quickly. She does everything quickly. I don't know how empathetic she is, whereas if I send you to Dr. E, I know you're going to get the time. If I send you to Dr. Rathkopf, I know you're going to get the time.
Okay.
So this is why I'm not sure, but it doesn't hurt to get a second opinion from her and then go see, or McHugh or Elaney or what have you.
Okay, thank you so much.
Could you tell us again where you live? I missed it at the beginning.
Fairfax, Virginia.
Fairfax, Virginia.
Thank you.
All right.
Okay.
Fairfax guys, reach out. You all have anybody who's local, send a note in the chat window to Ingrid and Harry and maybe you can talk to them offline.
Okay,
But we've got 3 or 4 Fairfax people in here right now. I'm sorry. I don't mean to rush you, but I got a lot of guys.
We understand. We
Thank
understand.
you very much.
Come back. The next meeting is next week on Tuesday, and update us. And if you need help with Elaney or McHugh, reach out to them. If you need help to get a quick appointment, let us know, and we can, we can backdoor if you're willing to go to Houston. But if you've got to get on an airplane, unless you're going to drive up to New York, you're going to get up on an airplane. I don't know. Something tells me that Elaney's might be the right person for you. I don't know why, but I also think McHugh could be really interesting because of what he's doing with PARPs right now.
McHugh was in New York.
He's at NYU?
McHugh is at Memorial Sloan Kettering.
Got it.
Okay, he's more junior to Rathkopf, but my guy likes him a lot. I got a guy seeing him right now, and he likes him. He's a young guy. He's 50 years old, and he's seeing him, and he likes it. He likes him. 51 years old. He likes him a lot. So, and I can connect you to him, so you can talk to him. And if I have any other ideas, I'll send you a note.
Thank you so much.
Very good. Thank you.
All right. Okay, so let's just see. The first person up is Dan S., who's also a Fairfax person.
Yes, I'm going to pass based on the time.
Okay. Okay, well, but let's see how we do at the ends. Hang in. I may be able to come back to you. But if not, just come back next week, Dan, right?
Sure. No problem. Thanks, Rick.
Okay. Put a big circle around your name so I know to come back. Alan Moskowitz.
Okay, I'll be brief. I had recurrent prostate cancer. I've talked about it a number of times in the past. And the last time I was with this group, a suggestion was made to me by Rick and others that I should consider doing PSA tests every 6 weeks or so instead of every 3 months. So I thought about it, talked to my doctor on it. He said, sure, if you want to do that and it won't make you crazy, go right ahead. And so I have done that. And so happily in the past 3-month period, my PSA hasn't gone up at all. It's been locked in at 0.85. And, plus or minus a little bit, but I'm very happy about it. And so, as I guessed, the doubling time has lengthened considerably. Now, if I look at the last 6 months,
it's about a 20-month doubling time. Now, as I said previously, the numbers are small, and when they're small, I don't put too much credence in them. But nevertheless, it was very good news and surprising. And I will do another test probably in roughly a week or two, and do them probably every 6 weeks, at least until I get a little bit higher and maybe can see a trend more than I have now. So anyway, that's for me the good news, just to update everyone.
Well, that is good news. Now, let me ask you something. So, would you recommend that anybody whose PSA is rising, they move to 6-week tests?
No, I wouldn't. I think it's only good when you have perhaps either a critical decision and it's urgent, and so that would be good. If you have very small numbers, as in my case, and the doubling time is 3 months or 4 months, then probably it's worth doing. But I have heard of people, not only here, but some friends of mine, they don't even do it every 3 months because they get too much PSA anxiety. So I thought that was interesting. One other thing separate from me, I see a doctor at Sloan Kettering. I'm in the process of switching to someone else at Sloan, and my essentially my current doctor said, we never really looked at the slides from your surgery back in 2013. And I said, well, isn't it irrelevant? I mean, Weill Cornell had them, and he said, well, why don't we get them? I want to have somebody here read them. And I said, well, if you think it's useful, it's fine. And we contacted Weill Cornell. The slides were not in great shape. And so they actually remade new slides from the original prostate tissue. And so what I wanted to mention is, I thought it was a waste of time because it had radiation subsequent to the surgery. So whatever cancer was on those original slides, in my mind, or in the original tissue, is perhaps somewhat irrelevant. Don't really know. However, when they did that, what they wrote back to me, and I still got to talk to the new doc on it, is that they looked at my Gleason and they gave it a 3+4, and they said it was largely a 3 grade, small amount of 4. In the original work that was done, it was a 4+3 with 85% of it. Roughly, quite not quantifying, but roughly qualitatively, 85% was a 4. So this is a complete flip. And Sloan looked at the original report as well. So I have to dig into it. In my mind, the new results are irrelevant, and I wouldn't even believe them. I go with the original test, but I've never heard of anybody going back and reading something so old, particularly.
Well, let me interrupt because time is of the essence tonight.
Yep.
I think what they're saying is that maybe your cancer isn't as aggressive as we might have thought, and that's being borne out now. And so they're just sort of using this as a proxy for the aggression of your cancer and how to manage it, Alan.
I don't see it, but that's okay. All right, that's all I want to find out. I will report back in July.
So report back in July, and hopefully, we can continue to manage it the way we're managing it, which is good. I mean, we always like it when there's no real increase.
Yep. Okay. Thank you.
Anybody? Hey, Rick, can I just ask Alan one question?
I'm just going to open it up. Go ahead.
Rick?
Yeah, go ahead, Len.
Oh, okay. So, Alan, did you say your PSA was 0.8 or 0.08?
0.8.
Okay. That's it.
So,
Okay.
Len, I mean, what's your thinking as to why they're looking at this? These
Exactly as you said, Rick.
Yeah.
So they want to know, like, what are they dealing with? How aggressive do they need to be? How alert do they need to be? So if they downgraded his pathology, that's terrific. And maybe you won't have such PSA anxiety anymore.
I think they're just covering their bases, looking for dotting I's and crossing T's. I just don't see it as that at all. I mean, I'll be surprised because I've not talked to the doc directly since they had the finding. You know, I've put some notes on the portal, but there's been no response. But I'll find out. As I say, I'll let everybody know.
Okay, who are you switching doctors to, Alan?
Charles Ryan.
Oh, you're going to see Chuck.
Absolutely. I will see him in July. I have an appointment with him.
Well, you tell him. Make sure you tell him I said hello. He's my old landsman. He lived in Mill Valley when I lived in Mill Valley. I go back a long way with Chuck.
I will mention it.
You're in very, very good hands with Chuck.
Okay.
Okay. So yeah, you'll be in very good hands with Chuck Ryan. Okay. Let's see. Norm Pollock.
Oh, you said I should come back when I got good news, so it's been a good 3 weeks.
Is that what I told you last time?
Yeah, you said you like to hear good news, so
I do.
PSA is undetectable.
Yes.
Testosterone's up to 512. I've been off ADT for a year now. I had my shoulder done. It turned out great. Only 5 days of pain. And we had our 50th wedding anniversary.
Oh, fantastic. So I was going to ask you about your shoulder.
Oh, 5 days on the pain meds, and it's been, everybody made it was a horror story. 2 more weeks in the sling, then start therapy.
And how long ago did you have the shoulder done?
3 weeks. Well, it was 3 weeks last Thursday, or 3.5 weeks.
Wow. How's Linda doing?
Yeah. Deteriorating.
Sorry?
Oh, she's deteriorating still.
Deteriorating, yeah.
Falls every now and then, but she's graceful at falling, so that helps.
Oh boy. Oh boy. Well, that is very good news. I'm very pleased for you. I don't know if we've got anyone else who's had a shoulder replacement in this group or not right now.
Well, you had the one guy call me, and he said it was the most terrible thing he ever did.
Yeah, Bill Franklin.
Yeah.
He had poor old Bill had a very rough time with it.
Yeah, it's like, yeah, the 2 days afterwards, that really hurt. I must say that hurt. Yeah. But after that, it eased off, and
okay, so
take a little more Tylenol.
So you're ready to start getting back to your pitching career, are you?
Yeah. Well, I got left on, and I'm a righty, so. But
okay.
I got a steering knob so I can drive. I drove 2 weeks after surgery.
Okay.
My old farm boy got the steering knob. Don't have any problem at all driving. So.
Okay. Well, listen, I'm real glad that you're undetectable, and I'm also very glad that that your T's back to 512 because that's significant.
Yeah.
So doing well. Anybody else want to chat with Norm?
Good to hear, Norm.
Yeah, thanks. I am getting fat sitting around with this shoulder, but
just stop eating.
Well, Mr. Muslim was passing through your part of the world last week.
Didn't stop, huh?
He didn't stop. No, He never called me to say who's in Tennessee. He never called me to say.
We're only about 15 minutes off I-40. I'd have fed him well. I'd have fattened him up too.
Okay. I'm just embarrassing him. I'm just embarrassing Muslin here.
He's
Next
ignoring
time.
It was raining like hell, and the cars were spinning out in front of us. It was really scary. We just kept going. We wanted to get out of there.
We've had some weather.
Yeah. All right. We're doing great as it so happens, and Julian left. He'll catch us next week. So we may have time to come back to a couple of people, but the next person on my list is Mr. Fisk.
Okay, I also have a bit of good news.
Yes, this is
in January. Well, the issue is radiation proctitis and bleeding.
Yes.
Dr. Paller in January referred me to Dr. Johnson Arbor at MedStar Georgetown for hyperbaric oxygen treatment.
Yes.
Had 40 sessions, 42-hour sessions, pressurized to 66 feet on pure oxygen that unfortunately weren't effective. She referred me to a Dr. Scott Friedberg at Capital Digestive Consultants, a GI doc. We had several discussions and I had a flex sig today where he used an argon laser. First off, investigating, he found an oozing spot right where he expected, adjacent to the prostate in the rectum. Saw blood actually oozing, and he tack welded it with argon laser, and was didn't perforate the colon, and was stopped the bleeding, and was very pleased with how it looked. And he said I should just keep watching and see if it comes back. But he was happy with with the results.
Well, I'm going to go to our argon laser expert here, who was treated with argon laser how many years ago, Fratello?
Oh boy, that's a good question, Rick. I would say maybe 4 or 5 years. Oh, maybe longer than that. See, I had the radiation in 2016, and then 2 years later, I had the proctitis. So 2018, so 7 years ago.
And how has it been since?
It sounds like you experienced proctitis in 2018.
That's
that
my
was
fault.
indeed about 7 years ago. Proctitis.
Sorry about that. That was Google.
It was listening to our question.
Listening, yeah. Okay, so yeah, I had to have 2 sessions. He said he wanted to be very careful. As you know, there is a risk of perforation. So first time, it didn't improve much, maybe 10%. Second time, it improved about 90%.
Well, he allowed for the fact that another session may be needed.
Yeah.
Can they do anything like that in the bladder?
No, I had
Richard?
I had a cystoscopy a couple of months ago, and other than having an old bladder, the doc didn't find any problems. There was also a little ring of tissue from radiation that is restricting the flow. It's like there's a little O-ring up in there.
Didn't you say you had radiation cystitis?
No, proctitis.
I thought you said, okay. Thank
Yeah,
you.
I apologize if I misstated or wasn't clear.
No, you said proctitis.
Yeah.
You said proctitis. Dr. John was taking a nap at the time, or maybe Ray came in and caught his attention.
I hear what diseases I have, no matter what people say.
But no, you see, I knew who to go to. I knew that if we went to Len, he would be very positive for you. So that's why I went to Len.
Now my GI guy said, I'm not going to do this anymore because this is as good as it gets, which was good enough.
Right.
So, like I said, I had it twice. I guess they don't like to do it more than twice.
Okay. Well, I had a bunch of blood work, and even though I had a iron infusion last month, all my red stuff is low, the platelets and percentages and all that. So I still have to deal with that. There's still something going on, but it's like playing whack-a-mole with all the stuff that goes wrong. You just fix one thing and wait for the next one to come up.
Yeah.
Did the iron infusion help the red blood cell count?
At the time, yes.
So I would just comment that I had radiation cystitis and lost a lot of blood. I had multiple visits to the emergency room, and I needed 2 courses of infusions. Each was 1,000 milligrams of iron sucrose. You know, they were about a year apart, and I'll call them the red numbers. They're all a little low, and I'm still working on what that might be. But I keep hearing anemia of chronic disease, and so good luck with trying to get the numbers back up. It's for me, it's been a sort of a little bit of a mental challenge, and at least one doctor said, in my case, you may never know why they won't go up, and you may have to live with it being slightly below normal. But consider a second course of infusions if your ferritin and some of the other things are low.
Well, I'm going back to the hematology oncologist with today's blood results and throwing them on her plate and saying, what do you think? There's also a reading SIG's neutrophil that says my body is fighting some sort of infection or inflammation. So,
did you have any side effects from the hyperbaric treatment?
None.
None. That's because you're an old warrior and you're used to it. You spent too much of your life in those hyperbaric chambers.
Too deep, too long.
Too deep, too long, right.
I was actually surprised at the travel rates in the chambers that they use. The pressurization and depressurization in the civilian chambers are about half what the military is.
Oh, okay. All right, so we have 2 people with their hand up, and first of all, Jim Marshall.
Richard, by chance, where did you have your original radiation and with whom? I'm curious.
The external beam was at Belvoir with Carlin.
Okay.
Carlin, and then he got me into the high-dose brachytherapy down at VCA Richmond with one of his med school buddies.
Okay, and did they do a spacer at all, or?
I asked about that, and they said no, because the tumor was actually pressing on the rectum, and using the spacer would probably cause more problems than it would potentially alleviate.
Okay.
And knew going in that there was the risk of harming the rectum.
Yeah. Okay. I thank you.
Yeah.
And Dr. John, you had your hand up.
Yeah, for Alan, I just wanted to differentiate between the anemia of chronic disease and anemia caused by blood loss in the bladder. Because the former, yes, is something that you don't do much about, but if you're losing blood, then your blood or your iron can be replaced. Are you still losing blood out of your bladder?
No.
Okay.
Occasionally there's a tiny bit, but my major bleeds are basically 2 years ago.
Oh, good. Oh, okay. Okay.
So
So then I agree. We'll go with anemia
I'm
of
not
chronic
losing.
disease.
It's a little. It's not significant. So I'm in good shape in that way. But there's some other reason why it's not coming up. I still have low testosterone. There's the competition of eating iron, taking iron, or having food with iron, along with taking calcium, and all these sorts of things that maybe reduce the absorption of iron from food and even from supplements. So, I've been changing how I do that and monitor that every, 3 or 4 months, and we'll see where I am.
Okay.
One more quick
Yes,
question, if I may, for
go ahead.
John. If, assuming that the bleeding has been resolved, can I expect the iron and platelet numbers to recover?
Yes.
Barring anything else going on?
Yes. If the blood cells are not being lost, destroyed, or failing to be manufactured in the first place, then your numbers will recover. Now, most of us in this room probably has mild anemia because of our cancer and our ADT, but it's usually mild. So you could expect to recover at least to that point.
And what kind of time frame? 6 months?
Sure, less maybe.
Okay.
But, okay, so yeah, because you're not losing any more blood.
Hopefully it stays stopped. Okay, thank you very much. Done.
Oh, okay.
Okay, we're going to move on. And Bob Bogosian, are you still with us?
I am.
Great. So please give us an update on how you're doing and what's happened since last week.
Right. I had a visit with Dr. O, and what I spoke to the group about in our last meeting was my PSA is 3.36, many scans, everything is clean, MRI clean, slowly going up. And the question was whether or not Dr. O would think of hormonal therapy. So I had the visit. He said, you're slow, your PSA is slow to go up. It's not, cancer's not aggressive. My doubling time, interesting, with my PSA slowly going up, my doubling time is getting longer, which is now at 1.5 years.
Mm-hmm.
He said, we can control this. PSA tests every 3 months. Maybe we'll do a PSMA scan in September. But I asked the question about going on hormonal therapy. He says, I just don't recommend it now because we're just looking at a number. He said, actually, it was my wife who said that, well, the number's going up. Nothing is aggregating. So if this continues, when would you consider hormonal therapy? And he said, in my case, if the PSA is between 7 and 10, doubling time is over 1 year, the scans are still clean. He said, I would then consider doing something like Nubeqa or something like that.
Mm-hmm.
But as of now, no, just monitor.
You don't know. I shouldn't have said I listened to Dr. O talking to Neil Love yesterday, I think it was. Somebody had sent me. Somebody had sent that to me, and I was very, very impressed with the way that he manages his patients, as I'm sure Len will endorse, and others who see Dr. O. And he takes a lot of time with his patients, and he tailors what he does very much to their background and their history. He doesn't have it's not like a reflex reaction. and that's exactly what I'm hearing. So there you go. I mean, I would trust him. If it were me, I would have a lot of confidence in Dr. O. I think you don't want to go on to hormone therapy if you don't have to. And Len, what's your response to how Dr. O's dealing with Bob?
Well, yeah, he does. Hopefully, you have the same experience I have, but he always gives me as much time as I need, which is usually, about a half hour, and he'll even allow me to talk about cases other than myself, and he'll give me the benefit of his wisdom. I just trust him implicitly. He's got so much experience. He's seen so much. Um, I, I've never failed to follow his advice.
I agree.
Yeah.
He was running very late. We did a video visit, and when I was up, I had probably 40 minutes with him, and he was not pushing. And he said, "Is there anything else that we can discuss?" And then waited and said, "Thank you." So he always gives time. And that's the reason why maybe he runs late, because he cares and he's talking to each patient individually, and he's chock full of information and experience. Chock full.
Yeah, absolutely.
Well, I think you're doing the right thing. I think you're going to see the right doctor. I think the doctor's giving you good advice. I think it's the way to go. Norm Pollock, what do you think?
No, just for my own curiosity, I mean, from everything I've heard, they like to jump on PSA fairly quickly, and he's talking about letting it go to 7. Is that what I heard?
Correct.
Yeah, but you see, this is Dr. O. He's looking at a man who was a 3+4 originally, who's whose PSA is moving very slowly. He's taking all of this into account. We can't see anything on PSMA scans. We can't see anything on Aximin scans. We can't see anything. So he's saying, look, if it's not there and things are moving so slowly, and Bob, God bless him, was diagnosed in 2007.
Yeah, I say I was just trying to get educated.
So that's why you take a doc who's very pragmatic, like Dr. O, and I think it's very, very helpful. Dr. Jack, you wanted to say something.
Yeah, I just wanted to follow up on the scanning quandary. And the only thing I noted in listening to Bob was that he never had a C11 choline scan. And I just wonder if maybe it wouldn't be a bad idea to jump up to Mayo in Jacksonville. Or where do you live, in Florida? Or
No, New York, Manhattan.
New York? Yeah, well, I think the only place you can get it, I'm not sure you can get it in New York. Maybe you can. But I would, if I were in your shoes, I would just feel a little more comfortable getting a choline scan and maybe asking them to do it from the top of your head to the tip of your toes, just in case there's something hanging on, in your skull or in your tibia or in your foot that they haven't picked up on, and to just get a good look with a choline, C11 choline scan.
But why would you go with a C11 choline, Jack? I mean, what's wrong?
Because
why not just an FDG? Why not an FDG PET?
Well, I asked him that last time, and for whatever reason, that was not one that was the group was very conversive about. So I'm just jumping over to something that hasn't been discussed.
Well, I mean, I think we're pretty conversant with FDG PETs, and we recommend them all the time, especially to be compared with a PSMA.
All right, I suggested that last time, but maybe you didn't hear it. But you said you had an FDG scan? Robert?
No, just PSMA, Axiom, MRIs, bone scans.
Either and or both. You know.
I mean,
Isn't Mayo the only one that does choline?
I don't know who else does choline, but
I've heard it's only at Mayo.
Yeah, that's what I've heard too.
But you could ask you could definitely ask Dr. O, does he think it's worth doing an FDG PET scan to see if there is anything else in the event that you're not. Have we ever seen anything on a PSMA scan for you?
I'm sorry, what was that, Rick?
Have you ever seen a result on a PSMA scan?
Everything has been negative.
Right. So,
Nothing.
you could, I think then Dr. Jack's suggestion is a good one. I mean, send a note to Dr. O and say, I've been thinking. Say Len Sierra suggested. There you go. You say Len thought, what about doing an FDG PET just in case you're not PSMA sensitive?
Well, I know his opinion of FDG scans are that they're useful for rapidly growing cancers.
Yeah.
Because it's radioactive glucose. Every cell in your body is using glucose. So unless the cancer cells are rapidly dividing and using a lot more glucose than the rest of your cells, it's not going to show any difference. And from what you told us, Bob, it sounds like you're growing very slowly.
Very slowly.
What about a CT scan with contrast? Did he mention that as a possibility?
It's interesting because when you do the PSMA, the first is a CT scan, and he was thinking of doing it with contrast. And I had it done in January, and we didn't do that.
Yeah, there's a big difference between the CT that accompanies a PET scan and a CT scan with contrast. It's a much better scan.
Mm-hmm.
The FDG PET is a much better scan, you're saying? Or not? Which is the better?
No, I'm just saying. Bob mentioned that. I think he said he had a PSMA PET scan with CT, right?
Well, I thought I thought when they do it, it is a CT scan, and then that's imaged over the PSMA.
Yeah.
I thought the first stroke, so they do a CT scan.
Yeah,
but that's pretty much like a scout film, just to locate everything on your body. It's not
right
what they consider a real CT scan.
Exactly.
Right.
I don't think the choline scan's hypermetabolic like the FDG scan and the Axiom scan. I don't think it's dependent upon the hypermetabolic aspects of the cancer. And he obviously has an indolent kind of cancer, and I think a choline scan is more apt to pick that up than an FDG scan.
Okay, I mean, I cannot get into which scans are better. The choline, the FDG, I think, choline scans to me are a bit like proton beam. I don't know that there's any real benefit, and the people who push them are the people who have the equipment. And so I'm skeptical about colon. What I would say is that you ought to have a discussion with Dr. O as to whether he thinks that if you were not PSMA, if you did not exhibit PSMA, what sort of scan would be the right scan for you right now?
Okay.
I mean, I think that's a very viable discussion of a question to send him, and then consider doing that. Guys, I just have to say, I've said it before. I'm getting questions, personal questions for me to answer whilst I'm moderating. I cannot do it. Yeah, I mean, it's very, very hard for me to respond, to run this meeting with 40, well, we're now down to 35, 45 people, new men, and people are asking me for my opinions during a meeting. It just doesn't go. You've got to, there's got to be some consideration here. Now, anybody who wants to wait till after we're done, I will stay on an extra half hour. I will take everybody's questions afterwards. But it's real hard for me to try and respond to everybody as much as I would love to. And I think everybody knows that. I'm sorry, but I have to say it. But hold on, and and I will try and get to everybody afterwards. All right, let me keep going. It's 7 o'clock. We've almost got through everybody. I've just still got to get to Al Latimer left, so John Graff is my last person, and then I'll take questions from anybody who arrived late or who wants to come back and talk some more.
Rick,
Al
this is
Latimer, back.
I got disconnected. I'm back.
Okay, well, it's John Graff, and then it's John Graff, then Al Latimer, and then anybody who wants to hang around for more. John Graff, where are you?
Hi, everyone. I'm here.
Hello. I heard you had a very nice conversation with Bill Franklin. Delighted to hear that.
Yeah, he checked in on me, which is very, very nice. I'm just in the middle of I started at IMRT. I did the HDR. Four sessions down, 21 to go.
Yes, sir.
And I guess what I'm beginning to realize is that this isn't the end of the journey, really. It's the beginning. I was hoping that I'd get through the radiation and it'd be over, but I'm realizing that is not the case at all. And I'm beginning to realize I don't have confidence in my medical oncologist, because like we were talking about last week, that he's a young guy, hematology oncologist, and I just don't know if he has the expertise. I mean, this stuff gets complicated, as I guess just listening to a few of these support groups is showing me. And so I'm basically kind of touching base with everyone, and I'm trying to reach out. And when the time comes, I think I'm going to need a medical oncologist. And I guess Rick said there's a good one down in Miami, Mayo Belusic.
Yes, sir.
And I contacted their office, and they said they weren't accepting new patients as self-referrals, but maybe if I got a referral from a doctor or an organization like AnCan, it might hold some sway. So I just wanted to kind of, when the time comes, maybe if I could get some help from you guys, that would be appreciated. But I'm still kind of looking around too. If anybody has any ideas of a decent GU medical oncologist in the Melbourne area, and it's rough.
Well, there's two things we can do. One is I'm going to ask Dr. Jack to lean on Dr. Belusic to take you, because he has a nice relationship with Dr. Belusic, and as a 61-year-old gent with high-risk disease, I think he'll accommodate us. We've got several other people who see Dr. Belusic. Don Rogers does, but I know Dr. Jack has a good relationship with him, and I know that Dr. Belusic knows about AnCan. So when the time comes, we'll give you some help. Is that fair enough, Dr. Jack?
Sure.
Thank you. So the answer, John, is yes, we can help you. The other guy who some of our guys see is what's his name? Schwarzenberg, I think. Not Albert. Hold on a minute. Let me just pull up. Paul Frieda. He is what's his name? Bear with me. I think he's in the Melbourne area, John, to be honest. I'm just looking. And I also know that he does see some Abraham Schwartzberg. He's at Jupiter Medical.
It's closer than Miami, but yeah.
But frankly, I would see Belusic. Everybody we send to him likes him. So
That sounds great. I appreciate very much.
did you get? Alexa said she sent you some resources on how to talk to your son.
Oh, I haven't. I have to check my email. Sometimes it gets shunted into junk mail. I got to go look through that because that would be appreciated too.
I asked her today, and she said she had sent. When I talked to her,
I got to look. It's probably in my junk mail folder or something like that.
If John, if not, send her a note, Alexa at AnCan.org.
Okay.
And give her a push, because she did. I asked her specifically today, did you do that? And she said she did.
I'm sure it's me, not her. I got to check.
Okay. All right. So, and just keep coming back to us, and yes, we'll get you to a good GU med onc.
Great, appreciate it.
For sure. Okay. And try and get together with Mr. President.
I will. I'm just not feeling very social now. I'm kind of like, the radiation's harder than it looked.
I know, but Bill Franklin is a terrific guy, and he's
like
very
a good guy,
easy to be with. And it'll be great also for you. You're in Tampa, you don't know anybody up there, and it'll be good it'll be good for the for you. Okay.
All right. Sounds great. Yes.
All right. So reach out to him and let us support you if we can. Okay.
Yep. Thanks.
Okay. Mr. Latimer, I'm glad you're still here. I thought, it's not like you to drop off.
Well, I've been on various adventures. So I've been on Jeff had 7 Jevtana treatments when now, and that's actually gone pretty well. I just had a new PSA PET, and the scan was better than it was when I started last October. My PSA is lower. I don't seem to have a lot of side effects from it, so I'm pretty happy with that. But 2 weeks ago yesterday, I went to the emergency room presenting with severe diarrhea. They ran some tests, and they say, hey, you got a partially blocked left kidney. And then they said, well, you also got an infection. And this was Sunday. Monday, I started the spike of fever. I didn't have a fever when I went in, but I started the spike of fever, and my white blood count went crazy. And and I'd been admitted by that point. And so they decided, well, they don't want to try to figure out what's going. They decided not to go after what was blocking the ureter, but I think I said that right. But they put a tube in my kidney to drain it to temporarily solve that problem while they're treating the infection. So that all went well. Monday night, my heart rate started to spike, and I went AFib. And so I ended up in the hospital all week, a week ago, while they're trying to get my heart rate under control. So totally unexpected. I mean, Saturday night I was feeling fine. So I'm in the hospital all week. They trying this drug, this combination, that combination. They finally got it under control. By the way, I live in Port St. Lucie now, and Cleveland Clinic has a big hospital up here. So I was at Cleveland Clinic. So after a week of being in the hospital, finally my heart rate's better. The AFib is under control, and I've been out of the hospital, and now they're this week they're going to try to figure out what's blocking the ureter. I suspect it's probably an enlarged lymph node, but the PMSA PET doesn't really show it. But the ballistic said, well, who knows? So that's where I stand right now. I'm home. I'm still pretty weak from a week of hell, but doing better, feeling better. And
So
I guess at this point I will keep you posted, because in the meantime my chemo is put on hold because I can't be doing chemo when I got all this other shit going on. So it's been a wild ride.
Okay, so a couple of things. I see Mr. Valens has his hand up, so we'll go to him. But have you been keeping Dr. Belusic in the loop?
Yes.
Okay.
Yes, I talked to him. I talked to him early this week about the whole thing. I almost decided to kind of go down to Miami and have them treat me there, but logistically, it's just a little much more complicated than here. So for the time being, I'm going to see a urologist, oncologist here about the blockage and get a diagnosis, and we'll go from there as to how I'm going to get it treated or where, I suppose.
Okay. I mean, I think that the best advice that I can give you is to be sure that Dr. Belusic is involved every step of the way. It's really, really important to keep your doctors involved because he's got your history. He knows you, and these guys don't. And you don't want them sort of doing something that doesn't fit with his plans. So please have them talk to him. The doctors don't like to talk to each other for some reason.
Yeah, I'm definitely going to be, well, I mean, I have Belusic's cell phone number, so I can talk to him when I need to.
Okay.
And also my chart. So, but the guy up here, I don't know. I haven't met him yet, but that's happening now. So we'll see. In the meantime, my kidney's working fine. I mean, I'm draining urine perfectly fine. So it's just the blockage, and I guess the fever's gone down. That is gone. My fever's long gone. I've finished the antibiotics, so definitely doing better.
Well, I'm glad to hear that. Now, wait, what did your PSA drop to after these 7 rounds of
you would ask me that. I forget. You want to know? I'll go look while we're talking.
Roughly. The last I heard, it was 170.
Okay. Well, let me just go pull it up here and only take a second. I have all this other stuff going on. I've kind of forgotten about my PSA.
Well, maybe that's not such a bad thing.
Let's see here. I can't wait to see what the hospital bill is here. I was in, they had me in PCU, not ICU, but PCU. So I was, I'm sure that rate was even, where the hell is my PSA test?
So, did you say PCU? I know what CCU is, but not
as opposed to ICU.
Yes.
So it's kind of like PCU is mini ICU.
Okay. What does P stand for?
I don't remember.
Okay. Okay.
I have some brain fog from all this too.
I'm sure you do. Well, listen, you can send me your PSA another time, but I wanted to try and get a grip on how well you're doing with the Jevtana.
Okay. April 11th, the most recent one, 184.
So it hasn't really gone up very much. Well, it's gone up and come down a little bit. So the Jevtana's holding you in bay.
It's been creeping up a tad, but none of that wild increases that I was having before I started this. So it's at least giving me some control. And like I said, the the most recent PSMA PET was better. The lesions were smaller.
Oh, so and the PSMA PET showed a reduction, huh?
Yes, it did.
Okay.
So that was good news.
Okay.
And
so Mark, what's on your mind?
Well, Al, I had something similar, but as you talk more, I guess they're not quite so similar. But I just had urinary blockage. Just having trouble getting pee out my urethra, and it backed up and it shut my kidneys down. And so I had nephrostomy tubes put in, and they were in for like 6 weeks just to drain the kidneys. And I was sicker than hell. So it sounds like yours is a bit different, but
well, it's not the bladder. I mean, my other kidney is draining into my bladder, and I'm peeing that kidney just fine. So now I see the pee from the left and the right kidney separately. So it's in the tube between the kidney and the bladder. That's where my issue is.
Yeah, so yours is in the ureter, mine was in the urethra, so it's a bit different. Okay, good luck with that.
Oh, well, thank you. And I had no symptoms. I had no symptoms from this. This totally came out of the blue. So why I had the diarrhea, I don't know whether it was related or not, but it certainly was serendipity that I was at the hospital and all this stuff came up when I was already in the hospital.
Okay, look, it's 7:15. I just want to see if anybody, there are a couple of people who arrived late. You gotta be here in the first 10 minutes if you need time. And we will give you time. Otherwise, you gotta wait till the very end. So anybody want to come back on, or anybody who arrived late, stick your hand up and we'll get to you. Stephen T. Yes, go ahead, Stephen.
Thank you. I'm near enough to the Carbone Cancer Center in Madison, Wisconsin, that I could reach there to get treatment, and I'm wondering if you know of a good GU oncologist or radiation oncologist or medical oncologist there.
Yeah. What's his name? There's Lang, isn't it? Len? Did Len drop off? Len dropped off. I think Joshua Lang, I think, is our go-to guy. There are more. Glenn, there's Joshua Lang is very good. Let me just check for you, okay? But I'm pretty sure that's the guy that we like. Joshua Lang. Let me put it in the chat window for you. Joshua Lang is one. And then another person, let's see, what's that guy Glenn's last name? I don't think he's quite as, he gets really good, this guy gets really good reports from his patients, but I don't think he's as current. Glenn Liu, Glenn Liu, Glenn Liu is another option. So those are two names off the top of my head. I'd have to sort of look around for more, but I put those two names in the chat window for you, Stephen.
Thank you.
Okay, Lang's been around. They've been around. Okay, Bruce Shrimp.
Hello.
Hello.
I've had 2 recurrences. I had proton. This is all at the Mayo Clinic. I was diagnosed in November of 2017. It was a Gleason 4.5. It was in a seminal vesicule. It had not spread, was not in the bones. I believe it was 6 weeks of proton beam radiation once a day. Then I started a course of Lupron before the radiation started. The radiation started in January of 2018. I was 18 months on Lupron. My PSA went down to 0.05 probably. Then over the course of a year and a half, it slowly started to rise to 1.5. Mayo pulled me back and they did cleanup radiation. I didn't know you could do that, but they did that. And then the PSA started going up again. And right now I'm scheduled to go back to the Mayo Clinic starting on May 20th for a series of tests. They have found 4 areas where they've got prostate cancer. It's still within what's left of the prostate. It has not spread. I'm on a course.
Let me just clarify. Okay. So the last note I have from you was in 2019. That must have been 6 years ago was the last time you were with us.
Yes, that would be about right.
Yeah, because I do remember your name. What's your current PSA?
0. And I forget if it's 5 or if it's 0.05.
Well, I would think,
and it was taken about a month ago.
Okay, so I would suspect it's got to be 0.5. And have they done these 4 areas? How did they find those? With what type of scan?
I honestly cannot remember.
Okay, so we need you to be a little more informed because it's hard for us to navigate you if we don't know. So have you had a PSMA scan?
Yes.
And what did that PSMA scan show?
That, I'm sorry, I just don't have that information. I could look it up, but it's all on my cell phone and I'd have to interrupt you to get to it.
Okay, well, couple of things. One is try and get the information. Come and see us next Tuesday. Tell us what's going on. Who's treating you right now at Mayo?
Dr. Bradley Stish.
Okay, so he's a radiation oncologist.
Yes.
Right. Do you have a medical oncologist on your team?
Not that I'm aware.
Well, that's what you need at this point. So you've got try and make an appointment either with sorry, I'm having a senior moment. Either Dr. Sartor or preferably Elizabeth. I would guide you to Elizabeth Heath. What I would suggest is go make an appointment before you do anything more with Dr. Stish, because the doctors at Mayo Rochester like to work in a vacuum. And that's not the best way. And what I would like to see is for you, stay with Dr. Stish, but get a consult from Dr. Heath, who is the best.
Heath, like the candy bar, Heath?
Heath, Elizabeth
Yeah.
Heath. All right? She's just wonderful. Tell her AnCan sent you.
All right.
She knows me. She knows Dr. Sartor is also there, but I think that you'll do better with Dr. Heath. Okay? We are talking about Rochester, right? We're talking about Mayo,
Yes.
Rochester, right?
Mayo, Rochester. And right now, they're thinking of doing cryoablation on the 4 areas. What stopped them is that one of them is very close to the rectum. And so I'm on a course of what's called Orgovyx. I've never heard of it before. And they're trying to shrink the tumors to get more space between it and the rectum.
Okay, so have you heard of Lupron before?
Oh, I was on it for 18 months. Yes, I've heard of it.
Okay, so Orgovyx is the same as Lupron. It just works in a different way, and it's a pill.
Right.
Okay. Now, but what I would like to see is I'd like you, before you start down this treatment path, I would like for you to get under the care of Dr. Heath. You know,
and she is at Mayo, Rochester?
She's the chief medical oncologist at Mayo, Rochester.
All right.
She's also a genitourinary medical oncologist. Her specialty is prostate and bladder, but she also happens to be the chief oncologist there, medical oncologist.
Right.
Okay. So I just put her name in the chat window for you, and that's who I would suggest you see.
Okay. I thank you. Is there any benefit in my attending next week, Tuesday?
Well, you know, there's benefit if we can dig down a little bit into what's going on, because it's hard for we think you've had a PSMA, but they only saw 4 areas in the prostate. It sounds a bit weird, because normally you don't see a lot in the gland from a PSMA. So, you know, that's why it just sounds a bit, 4 areas in the gland from the PSMA scan. I don't know. I'd like to get that confirmed by somebody like Dr. Heath.
Okay, I will go back through my records, because I have them all, and I'll be able to find that all out.
And, you know, if you come back in next week, don't come in as a new person. Just ask for time, and Ben will go through it with you, and we'll see if we can figure anything else out for you, and what to do and where to go. But you've got to be here in the first 10 minutes. Okay.
Yeah, I was a little late joining today because there was a problem.
Well, that's fine, but because we have so many people, we have a rule that you've got to be here in the first 10 minutes if you need time. Otherwise, you've got to wait till the back end. Okay. And
I appreciate it.
That's because we have to have some sort of system here. When you got 40, I know we've only got 11 now, but we had 45 people at some point today. So.
I know. I've been listening.
Okay. All right. Come on back next week. Are you getting our reminders?
Yes, I do.
Okay, that's good. All right. Anybody else needs any time? How are you doing, Steve L? I've got time this week to send a note to my friend Larry, and I will be sending a note to Larry. I've got some time.
Yes, I met with Larry about a month ago. Still trying to get my second appointment with him for a couple more months down the road, but he's not really set up to have clients locally. I'm his only client in Seattle.
Is that right?
Yeah.
Well, he needs to see more people. I mean, all my old boys are coming back into play. Chuck Ryan and Larry Fong. These are the guys I started out with at UCSF, and now there you are. You're seeing Larry and Alan Moskowitz is going to see Chuck Ryan. So what goes around comes around, right?
Yep.
All right. Well, that's about it. Stephen T. Yes, sir.
Sorry. If I give you 3 names from the Carbone Cancer Center, can you check them against your database and see if you know anything about them?
Who are the names that you're thinking of?
I have a John Floberg.
Isn't he a radiation oncologist or not? Is he a medical oncologist or a radiation oncologist, Floberg?
I believe he is radiation. Yes,
Yeah.
he is radiation.
Right. So you asked me for medical oncologist, so he doesn't fit the bill. Who's next?
David Gerard.
Don't know him.
Okay. And Douglas McNeil.
Don't know him.
Okay. Thank you very much.
Okay. What's wrong with Lang and Lou?
Nothing. I'm just checking these names. They were suggested to me by somebody else.
Oh, okay. Listen, I don't want to say they're not good. They may be terrific. It's just that I don't think we've had any patients that have seen them, so I can't give you an opinion. I'd have to go in and look at them. I'd have to go check see what research they've done, and et cetera, et cetera. But, we tend to refer to people that we know have come back with good, patients have given them good marks already.
Mm-hmm. Okay. Thank you very much, Rick.
Okay. All right. Mr. Muslin, if you're not too tired, hang on.
Hanging on.
Okay. All right. Can we close the meeting? I'm going to stop the recording.